So it's clear that this 28-year-old woman who's come into your pharmacy is suffering from constipation. The normal frequency that she passes stools has reduced from every day to every 4 days. We could recommend something like a bulk forming laxative as first line and give her some advice on diet and exercise. As you can see that she's lost interest in cooking, so therefore she might not be having a well-balanced healthy diet. In addition to this, she could actually be showing some signs of depression and therefore might need referral to the GP for this indication. As pharmacists, it's important that you look at the whole picture and not just look at the symptoms or the request that the patient is asking for within your community pharmacy, but look deeper within what the patient is telling you and having looked at the whole picture to see if there might be anything else going on. Our next topic is diarrhea, which is an increase in bowel movement that results in loose, watery stools. It affects most people from time to time. It's usually nothing to worry about, but obviously is distressing and unpleasant until it passes. The increase in bowel movements are normally associated with things like abdominal cramps, nausea and vomiting, loss of appetite, maybe headache, and we need to look out for those signs and symptoms of dehydration. So as we discussed earlier with nausea and vomiting, looking out for things like drowsiness and confusion, passing little urine, is there any dry mouth or tongue, is there sunken eyes, weakness, general tiredness, and also a sunken fontanelle in infants. There can be many causes. So it might be an infection such as a virus, bacteria, or maybe parasites. Anxiety can have a role, excessive alcohol, excessive coffee. It might be a food allergy, something like wheat or lactose, any medication. So most common things are things like antibiotics, and particularly clindamycin is what we have and what we call antibiotic-induced colitis. Antacids, so magnesium-based antacids, chemotherapy, non-steroid or anti-inflammatory medications, so things like ibuprofen or naproxen, statins, and obviously laxatives. Another cause can also be appendicitis. We need to find out whether this is an acute problem, so is quite sudden in onset, lasting about 5 to 7 days. This is normally caused by an infection such as like a viral infection or a bacterial infection such as E. coli, and this also includes things like bacterial traveller's diarrhea, resulting from drinking contaminated water or eating food that hasn't been washed. Chronic is more persistent, so generally lasting more than 14 days, and that can have a whole manner of causes. Again, infection, also things like bowel cancer, or maybe long-term medical conditions, so things like ulcerative colitis, Crohn's disease, irritable bowel syndrome, might be due to allergies, or something like celiac disease. Going through our WAM questions again, who is it for? Is it an adult, a child? Is it anybody elderly? Are there other family members affected, and has there been any recent travel? What are the symptoms? Is there any fever, any discomfort? Is there any mucus in the stool? Is the stool black? Is there any signs of bleeding? Is there any nausea and vomiting? Is it an acute or chronic problem? So has it been going on for longer than 2 weeks if it's chronic? Have they tried anything to help? And if they have, what? And has it relieved anything? And also medications. So what medications do they normally take, whether that's prescribed by their GP or something they've bought from a pharmacy or supermarket. Referral criteria: if there's any blood or mucus in the stools, black stools, persistent vomiting, like if somebody is really unable to keep any fluid down at all, whether there's loss, persistent loss, unexplained loss of weight, whether there's a high temperature or fever, whether this could be indicate an infection is present. Have there been any recent courses of antibiotics? Because we're thinking here, could it be an antibiotic-induced colitis? Has there been a recent discharge from hospital? Could it be something like MRSA or Clostridium difficile? Anyone who's pregnant? Is there any severe abdominal pain? And if there is this, we might be worrying something like appendicitis. So is the pain central? Is it radiating to the right side? And in things like in infants, you might see that they're screaming and pulling up their legs as an indication of that pain. Are they on any medication that could be causing an adverse drug reaction? In addition to this, diarrhea can also be a sign of withdrawal from drugs as well. And then looking at duration, it depends on the age. So children under the age of 1, if a diarrhea for longer than 1 day will need to be referred. For children and the elderly, 2 days, and adults 3 days. Diarrhea will normally clear up without treatment after about 2 to 3 days, but there are things that we can do to help ease the symptoms. Drinking fluids, using oral rehydration therapy, and also anti-diarrheal medications. We need to advise to drink plenty of water to avoid dehydration, and small frequent sips is better. And with young children, you can use like an oral syringe and syringe in small amounts of water frequently. You might also want to use liquids containing water, salt and sugar to help with the rehydration. Things like strong fruit juices and fizzy drinks should be avoided as they can make diarrhea worse. You can recommend oral rehydration therapy. So these will help treat the dehydration and replace some electrolytes and fluid. They're available as sachets and contain salts such as potassium and sodium, glucose and minerals. And each sachet is made up to 200 ml. And any unused solution should be discarded 1 hour after reconstitution, unless it's stored in a fridge and where it can be kept for 24 hours. If a patient has diabetes, then you need to recommend to regularly monitor their blood glucose, because obviously these sachets contain glucose. For a child under the age of 2 years, you need to recommend to go and see the GP. The oral rehydration sachets, dosing wise, for those under the age of 2 will be based on weight, or 1 to 1.5 times of their usual 20-hour feed volume. So it's best that they're referred to the GP. There are anti-diarrheal medications available, and they work by slowing down muscle movement, which allows water reabsorption, making the stools firmer and reducing that diarrhea. So loperamide is available over the counter, and there's also a preparation that's formulated with simethicone that can help reduce flatulence. So these preparations are not allowed or cannot be recommended for any children or anyone pregnant or breastfeeding. Practical advice: keep sipping water. If you have too much in one go, it will just go straight through the system. Get lots of rest and eat easily digestible foods, so avoiding things like dairy, fat, fibre and sugar. Hygiene wise, washing your hands thoroughly, sanitising the toilet, the handle and the seat. Avoid things like sharing towels. Make sure that any soiled clothing is washed at a very high temperature. Avoiding work and school while you have symptoms, and also for 48 hours after the last episode. For travellers, diarrhea, for prevention, advise that people use bottled water, even for things like brushing teeth. Try and avoid ice cubes, and with food make sure it's properly cooked, and make sure it's boiled or peeled. So we're back in your community pharmacy again, and a woman comes into your pharmacy asking for something for diarrhea. After your questioning on WAM, you find out that it's for her 11-year-old daughter who's had diarrhea since yesterday. She's otherwise well. She's got a little bit of tummy ache. Everyone else in the family is okay. There is no fever, no blood in the stools. Apparently she ate a sandwich for lunch yesterday that had been in a school bag for a few days. She hasn't tried anything yet, so think about what you would want to do next. So as there's only one more section for us to go through, I'd suggest pausing the video and coming up with your answers, and then we can go through it on the next slide. The important things to note here are that this is for an 11-year-old child. Everyone else in the family is well, and it looks like it's the likely cause is that she's eaten a sandwich that she really shouldn't have done, and it's caused the diarrhea. So rehydration is the main form of treatment here. We could recommend oral rehydration sachets, but no antidiarrheals as she is under the age of 12. Sip water frequently. Avoid things like fatty foods, dairy foods, lots of fibre and sugar. It should be short-lived, and if there's no improvement, then see the GP within 2 days. We are now on to our last condition, and that is irritable bowel syndrome, which is a chronic non-inflammatory bowel condition where there is recurrent abdominal pain associated with a change in bowel habit. Signs and symptoms can vary, but often there's a combination of constipation and diarrhea. Sometimes there is nausea, but not vomiting, and it can also be very lethargic and have backache. Abdominal discomfort is often left-sided and sometimes comes on after food and may be relieved by passing stool. Bloating can be quite severe, and so severe that people feel that they need to remove clothing. There might be fecal urgency, so the urgent need after getting up in the morning to go to the toilet, and then several times in the morning before and after breakfast, normally sort of loose semi-formed stools rather than watery, and sometimes they can be a bit like sort of pellets and pencils, and they may have mucus. Cause, there is no really clear cause. Possible causes are things like abnormal gut motility, abnormal central nervous system modulation of the gut, things like stress, diet. It does tend to be more common in women than men, and things like recent travel abroad or gastroenteritis can also be a trigger. Differential diagnosis for those other things that we might be worried about causing similar symptoms, things like diverticulitis, anxiety, premenstrual syndrome, endometriosis, Crohn's disease, ulcerative colitis, and also GI cancer. Reasons for referral: if there's any rectal bleeding that has been associated with a change in bowel habit, if it's a first presentation, if there's been any recent travel abroad or things like gastroenteritis, anyone who's pregnant or a child, unexplained weight loss, and the usual things of treatment failure. If anybody over the age of 45 is presenting with a changed bowel habit, and if there's any signs of bowel obstruction. Treatment is based on reassurance and a proper diagnosis. Treatment can be used up for a flare-up, and that will be, the treatment we choose will depend on the presenting symptoms. So for constipation, bulk forming laxatives. If diarrhea is the problem, we could use antidiarrheal agents such as loperamide. And there's also some antispasmodic agents that help with the abdominal pain side of things. If there's no improvement within a week, then the patient should see their GP. But a bit like gastroesophageal reflux disease, it really needs to be diagnosed by the GP first before treatment is commenced. Mebeverine is a muscle antispasmodic. It has direct action on the smooth muscle of the GI tract, causing relaxation and therefore helping with abdominal pain. It can cause things like skin reactions and facial swelling. And as we said earlier, it should only be used if there is a clear diagnosis of irritable bowel syndrome. Colofac isn't licensed to be used in pregnancy or above the age of 40 and should only be used for 18 years plus. And fibrogel mebeverine can be used in those aged 12 and plus. It is contraindicated in paralytic ileus. This is where there is severe pain and no bowel movements, possibly vomiting after an abdominal operation, and it is basically where the gut is not working properly. Alpha-ine citrate also has direct action on smooth muscle, helping with that abdominal pain. Again, can't be used in pregnancy or during breastfeeding. Common side effects include things like nausea, dizziness, itching, rash and headache. Hyoscine butyrbromide is not very well absorbed, but it can help with abdominal pain. It's not advised to be used in glaucoma because it can cause an increase in intraocular pressure. Peppermint oil takes 1 to 2 weeks to work. It does contain peanut oil, so you need to be careful with anyone with a nut allergy. It should be swallowed whole. It has an enteric coating to the capsule, so this ensures that it's delivered beyond the stomach into the small bowel. So if it's chewed, it won't be effective, and it can also cause irritation to the mouth and esophagus. So as I said, it's best swallowed whole, not chewed, and should be taken 15 to 20 minutes before meals. If it's the first presentation of symptoms, also check if there is any blood in the stool. Generally, for all the antispasmodics, they shouldn't be recommended for first presentation of any symptoms of irritable bowel syndrome. If over the age of 40, if anybody is over the age of 40, or it's sometime since they've had a last attack, or maybe if any symptoms have changed, if there's any blood being passed from the bowel, if there's a feeling of sickness, or if there is any vomiting, any loss of appetite or weight, paleness, tiredness, severe constipation, fever, recent foreign travel, pregnancy, if there's any abnormal vaginal bleeding or discharge, and also any difficulty or pain in passing urine. Practical tips: we can advise exercise. As with most things, increasing fibre intake and fluid intake if constipation is a problem. Identifying those trigger factors, so whether it's a stress or particular foods, and obviously trying to avoid those triggers. Having regular meals. If diarrhea or bloating is an issue, maybe trying to reduce the intake of insoluble fibre, so things like the wholemeal breads, rice, high brand cereals. Probiotics have got conflicting reports, and more studies really are required before we can make a firm recommendation on these. Diagnosis must be made by the GP first, and if they have tried treatment and there's no improvement after 1 week, then they should go back and see their GP. We've covered quite a few different gastrointestinal problems, and things can vary between different conditions. So just thinking about things as a whole and thinking about pain and location of pain. So that can sometimes help us distinguish between the different conditions. So if the pain is above the umbilicus and in the central area of the stomach, it's more likely to be something like simple dyspepsia. If it's below, then it might be something like irritable bowel syndrome or diverticulitis. Behind the sternum, heartburn or reflux esophagitis, and if it's more localized or specific, it might be something that's non-digestive. The type of pain as well can help you distinguish between different conditions. So if it's more of a general discomfort or aching, something like dyspepsia. If it's a sharp stabbing pain, it might be something more serious, so something like a gastric ulcer. If there is radiation of the pain, so moving from the breastbone towards the face or down the left arm, that could be a possible heart attack, cardiac pain. And if it moves to the back, the neck or the left shoulder, that could be indicating something like angina. Movement towards the right, biliary colic or gallstones, and severe pain moving towards the back could be something like a gastric ulcer. So after requests to have some more exam style questions during lectures, I've just written a few questions for you to have a go at. So I'd suggest reading through the questions, pausing the video, and then we'll go through them on the next slide. Looking at question 1, this is all about looking at reasons for referral. So you just need to go through one at a time and consider whether you would want to refer that patient or not. Obviously considering that they had no other red flag symptoms. So A, a 3-year-old child with vomiting that has been unable to keep fluids down for 2 hours. So if you check back on your slides, when we went through nausea and vomiting, you would refer a child if they were unable to keep fluids down for 8 hours. Question B, looking at an adult with constipation after being away on holiday with friends. So here it's the likely cause is to be a change in diet. C, a 40-year-old female with diarrhea of 2 days. Again, if you have a flip back to your slides looking at diarrhea, we would refer after 3 days for an adult. D, which was the patient that we would want to refer, so a male with indigestion where the pain is radiating down the arm. So this might indicate a cardiac nature pain. And then E, an elderly female patient with diarrhea for 1.5 days. So here we would be looking at referral after 2 days. Then question 2 was looking at treatment of constipation for an adult who had no other red flag symptoms. So just going through each medication at a time. Diaurolite is oral rehydration, so that will be used for diarrhea rather than constipation. B, which is the correct answer, a bulk forming laxative. C, loperamide, again is used for diarrhea. And D and E are both antispasmodics used for irritable bowel syndrome. Our next question is a short answer question. So looking at practical tips and advice that you can give somebody with dyspepsia and indigestion, but not only listing those tips, but trying to explain why we suggest those tips and how that might help the patient. So if you had just listed some practical tips, then you wouldn't have gained the 4 marks here. We were looking at explanation for each tip that you put down. So weight loss if needed, as this can help reduce pressure in the abdomen, and that pressure, increased pressure in the abdomen can have an effect on that lower esophageal sphincter at the end of the esophagus. Smoking, again, because that can relax the lower esophageal sphincter. Avoiding any aggravating foods to reduce symptoms. Again, a lot of those foods can affect the lower esophageal sphincter, or things like fatty foods or spicy foods that can trigger off dyspepsia should be avoided. So any alcoholic drinks, caffeinated drinks, again, can relax that lower esophageal sphincter, so we want to avoid those as much as we can. Avoid eating prior to bedtime, so we normally say 3 to 4 hours, and this is because when you're lying down, acid can then go back up into the esophagus. So trying to eat before 3 to 4 hours before bedtime will help prevent that happening. Dealing with any stress and anxiety, because that is a common cause of dyspepsia, and any medication reviews. But if there's any medication that the patient is on that might be causing dyspepsia, or one of those common medications that cause dyspepsia. Eating small regular meals to reduce the amount of food in the stomach, reducing that gastric distension. Chewing food properly, which gives time for the food to digest properly in less time, and therefore the acid is around in the stomach for less time. And if symptoms are particularly worse at night, using a pillow to help elevate the head, preventing acid from going back into the esophagus when lying down. So I'm hoping now that you will be able to list the common gastrointestinal disorders that you will commonly come across in a community pharmacy, that you can explain how to differentiate between the different conditions based on the patient's symptoms and history, explaining questions that you need to ask to help diagnose problems and obviously recommend appropriate management. Know those warning signs and when you need to refer patients, and giving appropriate management, describing appropriate management of minor ailments with over-the-counter products, and also non-pharmacological interventions as well. I hope you found the information useful. If you have any questions or want further clarification on anything, then please do not hesitate to email me.